This podcast is sponsored by PAX. Whether on water, on land or in the air, PAX bags are both versatile and flexible backpacks that are perfectly suitable for your requirements in the most demanding of environments. PAX bags are highly regarded due to their exceptional performance in pre-hospital and in critical care environments. Renowned for their durability, they endure harsh conditions while providing rapid and reliable access to essential kit. So their well-organised compartments and customisable configurations enhance efficiency in high-stress situations. PAX bags are designed with infection control in mind and are easy to clean and disinfect. Their highly visible colours and reflective strips add quick identification and adherence to quality standards, assuring reliability. The versatility of PAX bags caters to a diverse EMS providers, but also delivers vital equipment and durability and ease of use for pre-hospital critical care services globally. I've used PAX bags in a number of critical care situations and they're absolutely excellent. Please see the show notes for further details. Welcome back to the podcast. In this episode, we're going to start a mini-series on PTSD. So I had some feedback recently from the episode with Lucy Goff around the TRIM assessments, the trauma risk management assessments, around really examining the empirically proven talking therapies that work for PTSD and that TRIM assessments would refer through to. So what we're going to do is, for this Thursday, next Thursday and the Thursday after, is really look at EMDR therapy, so eye movement desensitization and reprocessing therapy with a consultant psychiatrist. What it is, some of the use cases around it, some of the evidence for it, really breaking down the components of what happens in the therapy room. Then we're going to look at PTSD, a really profound case of PTSD from a famous author, presenter, BBC presenter, Will Millard, and he takes us through really his experience of PTSD over some really profound and indeed visceral experiences on the ground from some expeditions he experienced. So we're going to go through, and then some of the treatments he got for his PTSD diagnosis. And then finally, we're going to look at CBT with Seth Gillihan, who is a multi-million viewer, award-winning author and indeed podcast host, on what CBT is, some use cases, really break down what happens in the therapy room for CBT and how that looks. So welcome back to the podcast with myself, Owen Walker. So today I have Dr. Abigail Pamich with me talking about eye movement desensitization and reprocessing therapy. So Dr. Abigail is a clinical psychologist with over 20 years experience in therapy and mental health. She runs a private psychological practice based in the UK, leading a team of 12 experienced therapists. Dr. Abigail and her team offer remote therapy to clients nationally and internationally. And Dr. Abigail is also growing her YouTube channel, exploring different types of therapy. And we'll put that in the show notes at the end of the session. But exactly what we wanted to focus on today is one of the approaches that Dr. Abigail uses, which is this EMDR therapy. So Abigail, welcome to the podcast.
Thank you, Owen. I really appreciate you inviting me on here to talk today.
It's great to have you on, actually, Abigail, and just to bring forth some of your experience and empirical knowledge from your practice, actually. So let's just get right to the heart of the subject, if that's okay, and just look at exactly what EMDR is.
So EMDR stands for eye movement desensitization and reprocessing, and it is a mouthful, which is why we shorten it to EMDR. So in a nutshell, Owen, rather than free flow talking that is the basis of many therapies, the therapy is quite structured and it follows an 8 phase structure and involves something called bilateral stimulation, which is actually a bit odd, and it's stimulating both sides of the body, back and forward. So, Owen, it's designed originally for trauma, but now it's used in many areas where there's just something holding a client back. This could be phobias, public speaking, recovery from abusive relationships, anxiety, depression. And I tell you what, it's profound. It's just changing the course of therapy across the UK and the world.
So Abigail, why is it sort of important for us to talk about EMDR at the moment?
I guess because it's just quite unknown by the general public. It's effective and it's accessible. And like a lot of other different therapies, a lot of them are really difficult for people. They're not necessarily easy to access. So EMDR is effective because, people talk about trauma They might go to counselling. But to be fair, it doesn't always help just to talk about it. Some people say it makes them feel worse and they can get on with their life. But the way we understand trauma, really, it needs to be actively processed. And that's what EMDR therapy does. And it's accessible in the fact that it can be done online. And COVID has shown that in the safety of your own home. And it's opening up therapy to people who would normally be very nervous about trauma therapy, where this is short, sharp, and gets to the point. And I just hope this podcast allows more people to hear about EMDR.
So you mentioned bilateral stimulation, actually. Could you maybe dig into that and just tell our listeners exactly how it works?
Of course, well, bilateral stimulation is something where you stimulate both sides of the body. So this could be tapping on the hands, or we have like little tappers that do a little electric, very gentle zappers in the hands, eye movement back and forward, sounds in different ears. It's stimulating both sides of the body and the brain whilst the client is thinking of the trauma memory. So it's not painful at all. We don't want this to hurt the clients or hurt their eyes in any way. And again, it can be done remotely when somebody's sat in front of a computer screen. But the essence of EMDR is there needs to be some form of this stimulation backwards and forwards across both sides of the body.
Gosh, that's really interesting, actually, and belies a lot of maybe, like we were saying, off camera, left and right brain activity. So, is it effective in your mind?
It is incredibly effective, but I will say it's also a bit weird. I'll be honest with people, it's unusual. And we'll talk more a bit about the research on it, but it's been so heavily researched because it is just a bit odd. You go to counselling or therapy, you think you're going to be talking, and suddenly you're sat there with zappers in your hands backwards and forwards. But I tell you what, Owen, in my own clinic, I have seen incredible change with people overcoming past hurts. And that's why it's been researched so much, because they're saying, well, how can this stimulation be working? But research has shown it's the bilateral stimulation that's the important factor. It's great, all these other parts of it and the connection with the therapist and being heard and validated. But research has shown you don't process the trauma without that back and forward stimulation across the body. So that has to be part of what takes place.
So as you were saying before, Abigail, actually, as inquiring clinicians, we're always looking for the empirical research. Could you maybe speak to the research which has been conducted into EMDR therapy?
Yeah, I'm really glad you asked this, because I think we need to be aware of the research. We need to have confidence. And if somebody goes for EMDR therapy, they need to have confidence that this isn't wacky. It's based in neuroscience and it's profound. So the research that they do is what we call randomized controlled trials, RCTs. So they're the most powerful form and the most expensive form of research. There's a Journal of EMDR Practice and Research in 2019, and they did a review. And they found that there was more than 44 RCT trials that showed EMDR was effective in PTSD, in early trauma, in traumatized children, and they just showed it was incredibly effective. There's another 28 RCTs coming up showing it's effective in depression, bipolar, psychosis, anxiety disorders, OCD, substance use, and even chronic pain. So we can really fall back on knowing that this is a therapy that has been shown to demonstrate it is effective. And then that helps us believe in it and deliver the best possible therapy to our clients.
So you were saying before, it's not necessarily well known, and I would concur with that. I didn't always know about EMDR therapy, but in your mind, is it a new treatment, Abigail?
It's actually been around since the 1980s, but it's gained a lot more traction, particularly with COVID and it being done online. A lady called Francine Shapiro, she first identified that by this eye movement, you could overcome events that were really disturbing, and they could just, this eye movement backwards and forwards could take away or could process the pain of those trauma events. So really, it's become quite huge. I'd say over the last 10 years, to the point it's now in NHS. It's a NICE approved treatment as well. It's used extensively across the world. Hospitals are using a lot with people who have seen COVID, really difficult situations in wards. and it's shown to be fast and effective. And I guess, as I said before, accessible because it works so well remotely. These pieces of software have been designed now where we can do this bilateral stimulation in the eyes and also with the ears and also with the tapping while somebody's sat safely in their home. And I'm working with people all over the world and processing trauma every day. And it's phenomenal. And it's such a gift. So I just hope we can spread the word a bit more with this podcast.
So that's really interesting, actually. And we all come to different therapies in our own ways. And the way I found out about EMDR was through a fellow colleague, a paramedic that received EMDR to good effect, to amazing effect, actually. And so my question would be, how did you integrate and even find out about EMDR to integrate it within your practice?
When I trained on my doctorate in the early 2000s, it just wasn't even talked about. We did traditional CBT trauma therapy, which I might mention later on, but that was very, very different. And it's more in the last 5 years that I became just frustrated with needing to put people through exposure to trauma over and over and over. Heard a bit about EMDR and I investigated it, and I just felt this is too good to be true. Surely processing childhood trauma in 15 sessions, I mean, this is normally years of work. So I did the training in Birmingham face to face and started practicing, and it's just revolutionized my treatment. And I find probably 80% of my client load now, I use EMDR at some point because it's faster, it's more pointed straight into the trauma. And it's much less upsetting for the clients themselves. And you can use it in so many issues. And that's where it's growing now. And it's gone from this traditional PTSD and people in combat to realizing that you can use it across the board with bullying, difficult experiences at work. And it's just having profound effects with all kinds of presentations.
So you mentioned analogs, and an appropriate analog might be, like you said, CBT, so cognitive behavioral therapy. Could you maybe unpack some of these other therapies just to show as a comparator how efficacious and good EMDR therapy actually can be?
Yeah, I mean, so much of what we do as a clinical psychologist is evidence-based. That's how we work. We're scientists, practitioners. So the CBT that we use for trauma, or that I was trained in, has a really good evidence base, but it's tough. So a client needs to relive their trauma moment by moment, and we often tape it, and then they need to listen to it 3-4 times in a week over and over. And we, what's called, habituate to the trauma. So it becomes, through exposure, it starts to take the sting out of it. And then we slowly, we might update it with new information that I am safe now, but it takes weeks and weeks and weeks and hours. And it takes a very brave person to face their trauma and go into it continually over weeks. It does work, but for some people, they just, particularly thinking children, adolescent, we just can't make them go into their abusive experiences every day. It's just unethical. So EMDR is very different because we ask the client to turn to the trauma momentarily, just to turn into it and think about it. And then we get in, then we process it with a bilateral stimulation within like 30 seconds. And then we go on to the next memory. So it's touching, you touch the trauma and then you process. It's a much faster way of working and healing these memories than traditional CBT, which has still got a place and is still effective and people are being healed from it. But you just can't, it's just so amazing how quickly EMDR can work.
So Abigail, could you speak to the type of clients that do come to see you and maybe some of the difficulties that they present when they're in consultation with you?
Mm-hmm. I love my job, Erin. I have so many different people that I see, and I'm so honored that people share their stories with me. And one of the things that I guess in my brain is I categorize things into big T's and little T's. And I talk about this with the clients. So big T's are the big traumas, like the major car accidents, the severe abuse, seeing combat, just real significant traumas. And we can pretty much line them up with EMDR quite quickly. But we also have something called little T's. So these are traumas that are still very painful, but they might be seen as more milder difficulties with a blocking event. Somebody can't move forward. Maybe they've had an abusive relationship and they can't get the person out of the head and the negative words that they call them a failure, or it's an anxiety triggering event like giving a talk and it all going wrong and everybody laughing, or this sense of imposter syndrome that I'm just not quite good enough and everyone's going to find out. We can often trace those little T's, those little traumas back to early blocking events that are stopping the person move forward. And we try to educate our clients and do a practical focus so they can learn maybe what these blocking events were. They might not know them to start with, and we go back and we find what those are. And then we can process those and actually frees them up then to overcome whatever it is that was stopping them from moving forward. So this could be anxiety, it could be depression, it could be relationship breakdown. As I said before, a big one is imposter syndrome, people very highly qualified and struggling to feel safe and like they're good enough in their jobs. And all these different things now, the big traumas and the little traumas, can stop us from moving forward. So EMDR can be used in multiple presentations.
So Abigail, from a neurological perspective, how does, in your mind, EMDR work with clients?
Well, I guess without going too much into kind of the technical parts of it, normal long-term memory just gets filed away with images without the emotions. What you have for breakfast, you might just remember that, but it's just filed away. But when we're extremely upset or in terror or fear or hurt, the experience kind of gets stored in a capsule, and it's a sealed capsule. And in this, you have emotions, thoughts, and physical state that were happening at that time of the event. So therefore, when the capsule then gets triggered at a later date, the same thoughts, emotions, and physical state also get triggered that the person was experiencing back then.
So Abigail, could you maybe speak to an example of that within practice?
Sure, yeah. These capsules are key. Oh, and they're absolutely key. So imagine you're in a car accident. You're just about to hit a wall. You had the experience of terror and the thought that I'm going to die. You break out in sweat. Your heart is racing. The tension is just palpable and you feel sick. That experience becomes encoded in a capsule of trauma. We wind forward 6 months later. The client sits in a car. Suddenly, they experience terror. The thought, I'm going to die, physical anxiety, tension, it all floods back as if it's happening right there and then, but they're safe. But they don't know that because the capsule has been activated. So we treat with EMDR. And what this is we open up that capsule. We open it up and we process that whole experience so it gets filed away like normal long-term memory. We take out the emotion through processing and we install a new cognition, a new thought. I am safe now. So if that person in the future sits in a car, they don't get that capsule triggered because it no longer exists in this completely tight form. We've opened it, we've processed it, and we've installed new information. This is called adaptive information processing. It's a fancy way of saying we've got new information, it's been stuck in the capsule, because when it's sealed, that information that I didn't die and I'm safe can't get in. The body still thinks in the state of just about to die. But when we can put the new adaptive information in, the body then feels safe. So the adaptive information that we process and put into the capsule in this instance is I'm now safe. The body calms and the person no longer gets triggered. And that's the essence of EMDR.
So how do we maybe differentiate between trauma and anxiety? Are they the same or are they quite different?
That's such a good question, because I think that's what takes skill as a clinician and experience. And sometimes it's just a gut feeling until I get to know the person, because it's the same systems that are involved. Really, if we've got the amygdala, which is the little bits in our brain, and that sends a signal to the body to release stress hormones when we're in danger. And these stress hormones create all them funny physical symptoms that we don't like: sweating, heart beating faster, shallow breathing. And that's anxiety. That's what anxiety is. We all get it. We go in and out of it regularly. It's perfectly normal. But my experience shows that when it is anxiety and it stops at that point, you can talk yourself down. Something called our executive function, our thinking brain, the front of our head. It's online, even if it's just a little bit. We can teach people breathing techniques, positive self-talk, reframe the situation. This is where things like NLP work great, and the CBT, cognitive restructuring, it's brilliant. And for most people, that's enough. The anxiety slowly dissipates and they can manage it. Often people I see have done all this. They've been to CBT, they've tried it, and they just can't overcome it. And that's when there's something red, there's a red flag. And it says, okay, this is trauma. This is unprocessed trauma. When somebody has a trauma reaction, they cannot think clearly. They're intelligent. An intelligent human is flawed, consumed by fear. And these are the techniques, they just don't work. And that's when I think, okay, this is trauma. We need to shift gears completely now and help this person process this trauma capsule, because this is over and above just anxiety. It's something that's sealed and something that we need to break open and process.
Abigail, could you speak to some sort of case scenarios of this to sort of contextualize that at all?
Yeah, I think it always helps, doesn't it, to think about this in a real life situation. So yeah, let's think about, let's call this person Andrew. So Andrew, he's in his 30s, successful at work. However, any form of criticism sends him into a deep anxiety state. He just can't function. And it activates a fear state. So say he gets criticized by his boss, useful constructive criticism, but he can't sleep. He can't eat. He's got to take time off work. I mean, this is absolutely floors the poor guy. It's terrible for him. He's been to CBT. He does the breathing. He does his thought challenging. He visualizes that he's okay, but nothing works. He just gets floored. So we look at his early experiences and we think, well, what's the touchstone? What's the trauma behind this? Because I'm getting a hint that this is more than just an anxiety reaction. We find an early trauma where he's just little, he's 8, and he's severely criticized at school. There's a teacher who ridicules him and laughs at him. And in that moment, it's so overwhelming that he doesn't process the experience, and it becomes sealed in a capsule, like we've said. He feels powerless, shame, and feels depression. And this all becomes encoded with a belief about himself of I am useless. So this is where it becomes a problem, because when Andrew's triggered at work, he's not able to think, okay, I'm a grown man, I'm successful, it's just a criticism, I can learn from this. Because when the capsule is triggered, so does that cognition of I am useless get triggered, and I am powerless. And when the capsule is triggered, he almost becomes 8 again in his brain. He's useless, he's powerless, there's shame, there's depression, there's nothing he can do, and he can't think through his options. And all those emotions come, and the shame and depression, everything is overwhelming. And actually, when I talk this through with Andrew, I would help us look together at that actually when he gets activated, he loses his adult brain and he's going back to this little person. Even though he has power and control, he feels like he doesn't. And that's what we then need to focus on to help him recover.
So how precisely would EMDR therapy help? So you have spoken to, you're right, this prevailing capsule just breaks open and all the emotions pour out all across his conscious waking brain. He's got no control over it. So so how would you use the EMDR to craft recovery in Andrew?
We'd be really structured. He'd know exactly where we were going every session. It's a very solid structure that we put on EMDR. And ultimately, the process is identify the early trauma. So we'd go back to the first time he felt this and the worst moment of it, and we would process it using bilateral stimulation. And then this would take away the emotional pain of it. It would literally start to file it away. And then we'd install new information. So once we've got these emotions about the event down to really low, then we'd install the new adaptive information of a positive belief of his choice, such as, I'm good enough, I'm just as good as other people, or I can take criticism, I'm fine, I can cope with this. Something that is adaptive and is actually the reality of the new information. So there's three things. You identify the trauma, you process the trauma using some form of bilateral stimulation, and then you install the new adaptive information.
That's fantastic, actually. So just for context, Abigail, if we were in the room with you guys watching EMDR happen, how would that look to an outsider?
Well, hopefully you'd see somebody who felt very safe and very comfortable with their therapist because they knew they were going to go on a journey together. It's not like one person is the expert because we don't know what's going to come up. So we build a trusting relationship and then we journey together through the EMDR and what the mind comes up. So if you're watching in an actual therapy room, you might see a big light bar about 1.5 meters wide where the light goes back and forwards, or they might be wearing earphones where they've just got the noise back and forward. And what you'd be watching is the therapist saying, inviting the client to think of the trauma. And then once they've thought of it and brought it into short-term memory, they then get exposed with the bilateral stimulation for just about 30 seconds. The client just relaxes and follows it, whether it's a light or sound or the sensation in the hands. And then the therapist asks, what comes up? That's all we want to know. Just a headline, just a statement. There's no discussion. You say, what comes up? And Andrew might say, I'm remembering the other children laughing. And then you'll say, just go with that. And then you process it again. And it's just this back and forward. What comes up? Processing what comes up. We talk about being on a train and what the images that come up and the emotions and the memories, sensations are just like the scenery going past. And we're journeying together on the train, looking at the scenery and everything that comes up, we process. And then we move to the next bit and then we process. It's often a very relaxed experience, but fundamentally people need to feel safe and trusting. And all EMDR therapists should go through this process before and explain exactly what's going to happen so the client is fully in control. We also have a stop signal. So if at any point they don't like what's happening, or uncomfortable, put your hand up and you stop. Completely in control of the session.
So it sounds like the central tenet is this bilateral stimulation. Abigail, why is it so crucial to the therapy?
There's something so powerful about it, Owen. So powerful. Initially, we're thinking, is it mimicking REM sleep? Because if you've seen somebody in their eyes go back and forward, back and forward, back and forward, and they are processing, so it could be that. We've got another theory emerging that it's loading the working memory. That when you watch, sometimes we ask people to watch the ball going back and forward and name the colours as well. And that does process the memory. So it's something about the capsule being broken open. We can't identify precisely what it is. And I think there's more research into that, but we all agree something in the bilateral stimulation is powerful and it's life-changing.
So you said it can be done remotely, Abigail. You said, you can do these consultations both in the consultation room and maybe over a platform, streaming platform. How does it look and how would you do it online?
It's surprisingly easy. When we first moved to remote with COVID, I think we were all a little bit anxious about, okay, how are we going to do this? And I've just been blown away. The software that's been produced is phenomenal. So I would send a link to the client. I mean, we'd have a chat first, and then we'd agree, let's do some EMDR. I'd send a link to the client, and the client downloads the link, and they see the screen that I control. So, for example, if we're processing school bullying, it might be the picture of a schoolroom with the ball moving across, and I can upload different pictures. So, for example, somebody could have a bike accident. I will take photos of riding on a bike and upload the image of the front of the bike on the road. So it's something, it needs to be triggering them in some way. And the ball goes back and forwards. I can see the client's eyes really well because they're sitting very close to the screen. I can control the the sounds, the ball movements, the colors, everything from my side of the computer. And it just works brilliant. There's no travel for clients. It can be quite upsetting to do EMDR. There's something called an ab reaction where people hit motion, and we see a lot of emotion being released. And for a lot of people, that's so much nicer to be safe at home with that, rather than having to then leave a therapy room after being very upset. I find it adds to the ability to process, to be safe at home. And say the software is so helpful that's coming out now. And most of the EMDR I now do online. And I think I will keep doing EMDR online. I think I prefer it to the therapy room. I have to be honest, simply because it just gives such a more positive environment with being able to control the amount of bilateral stimulation that takes place.
So could you maybe speak to how you know which memories to focus on with bilateral stimulation? Because it sounds like you have to be maybe a bit of an anthropologist and really and also a bit of a detective to try and get to the precise memories.
Yeah, I think you're right. And what we do is something called formulation, and that's a fancy word for how everything kind of hangs together. So in EMDR, it's a very simple formulation. What's the past triggers, the touchstone where this might have started, the present triggers, and the future. How do you want to be? So we go back to childhood, because this is when these capsules were often formed, and we just look back at that time and we try and understand how it all began. And a formulation is very different for every client, and we talk it through. We have a couple of sessions where we plan what was the past memories, what's the present, what's the future, so we always know exactly what we're working on.
So could you maybe speak to an example of this formulation with a client, Abigail?
Yeah, sure. Thinking about Andrew. So I think I mentioned before with the formulation past, present, and future. So Andrew, his past trauma would be that memory of a teacher, which he might not know when he turns up. We do discover that often in therapy. It's not always obvious to people. So the present is him being triggered the last time he was really triggered and went down from the criticism of his boss. And the future is called a future template. And that's how he wants to feel. So we imagine him being criticized in the future and feeling confident and taking it on board and feeling safe and coping with it. So it's different for every client, but it just gives us a very clear roadmap so we know what we're doing together every session.
So looking at the trauma itself, if the client isn't necessarily clear on where the trauma is coming from, how do you hone in on exactly the articulation of the source of the trauma?
I think that does fundamentally come to getting on with your therapist, feeling safe with them, because there needs to be a therapeutic alliance, as it's called. So you're able to go on that journey, because when it's a big T, it's a trauma. It's obvious. I turn up, I've had a big car crash. Everything was fine before this. This is what started it. We know what to work on. But these small T's are not so obvious. So we might do what's called a float back with a client, where we go to their thoughts and feelings and body and emotions and everything that happens when they get triggered. And we float back and we say, tell us about the time when you felt like this in your adolescence, in your childhood. It may be a completely different context, but when was this seed planted? When did this begin? And honestly, I mean, sometimes as a therapist and the client, you're so surprised because neither of you expect it to come up, this thing that happened when they were 5 or 7. There's no sort of logical connection, but the mind is holding on to it. And that's when the seed started, that started the capsule, that started the trauma. So this is quite an exciting point, but you've got to have a lot of trust for that point to work well.
So, Abigail, could you maybe give an example of a client from your anecdotal practice that's maybe not aware of where the trauma began, but how you did the detective work to get to the source of the trauma?
Mm-hmm. Well, thinking about a female now, I guess I could give an example of, imagine somebody's called Jo, and she has intense fear each time her partner goes away with work. She's unable to work herself during this time. She can't sleep, she can't eat, she can't calm herself. The CBT techniques don't work. She just falls apart. She might come to therapy where that's the problem. I can't cope when my partner goes away. However, we do a float back. So imagine we do a float back with her, and I say, what's the first time you remember feeling like this? The first time you remember feeling distraught that somebody's left and that there's going to be this catastrophe. And on this one occasion, it was her grandmother. She remembered her grandmother leaving, and she never saw her again. She died, and it was an unexpected death. But that capsule, that catastrophe, was learning that she died and having that thought, I cannot cope. This is a catastrophe. I cannot recover. And that moment of learning about her grandmother going and then learning about her grandmother's death became encoded. So when her partner left, this was being triggered. She didn't know. I didn't know. We discovered this together. This was being triggered, this catastrophe of I cannot cope with this pain was being triggered. And this sense of absolute loss, way above what was happening with the partner. And fortunately, the float back revealed that. And then that gave us something that we could work on. And again, as I said before, we identified the worst part of that moment of learning about a grandmother passing. We processed that using bilateral stimulation. And then we installed the new belief of I can manage this. And then we do that with the present trigger and then the future template. So then when the partner goes away in the future, she has a thought, I can manage this. And that is what she completely believes.
Abigail, what else does the therapist do in an EMDR session that would complement this float back and the articulation and the bilateral stimulation? How does it look in a sequential fashion?
Well, it's interesting, because when I first started learning EMDR, you kind of think, oh, you just follow the manual, just follow this 8-phase structure that you're told to do. And that includes getting to know the therapist, assessing for risk and stabilization, and then introducing the bilateral stimulation, and then doing the formulation, all those things we've talked about. But over the years, the more EMDR I'm doing, I'm realizing it's so much more subtle. To be a good EMDR therapist, you've got to recognize something called looping. And that's when somebody might get stuck and this adaptive information processing isn't working. The new information isn't getting in. We do something called cognitive interweaves. So that's giving a little nudge, helping the capsule be updated a little bit. So say, for example, somebody might have been in a car accident and be stuck in that, I'm going to die, I'm unsafe, I'm going to die. And they're sort of stuck, the looping, you do the bilateral stimulation, they're coming back to the same thing over and over. You might say to them, did you die? And they'll reply with, no, I'm safe now. You've got that's new information, you process it. And they're processing it in mind with the trauma. And when you do the eye movement, it all gets kind of put together. And then you might say to them again, are you okay? Yes, I'm safe now. When did this happen? It happened 6 months ago. Yes, I'm safe. Process. You install these cognitive weaves, these little nudges, but you need to know when to do that, because sometimes you've actually just got to get out of the way and let the person process. And that takes quite a lot of understanding to figure out when to do that. Another part of EMDR is, and I love this bit, is installing resources. So at the beginning of therapy, you find, what are the positive people around them? Who are their supports? Where do they get their wisdom from? And it might be their best friend, or it might be them now, grown up, they know a lot more. And then in the EMDR, if they get a bit stuck, you bring these resources in. So say, for example, it could be, say we go back to Andrew thinking about at 8 and the children are ridiculing him. In the EMDR, we'll open up the capsule, we'll take him back, and then we'll bring him in now as an adult. And he might walk in the room and he might say to himself, you know what? You're safe now. You'll get over this. These people don't matter. You'll be successful. You'll be well. Or we might physically hold the 8-year-old him and just say, you'll be okay. You're strong. You can deal with this. And it's a visual way of bringing this adaptive information from the present back into the capsule. And you could invite your best friend. I've had people, they've had like 5 people turn up, their mom, their best friend, them as a grown up, their boss, all of them going back, turning up in the trauma and saying, we've got you. It's okay. It's safe now. And then that gets processed and installed with the trauma capsule, and it takes away the pain. And then when that trauma gets triggered again, all the characters turn up in their mind again. and that idea that they are safe. So that installing resources is so powerful. I love it. It's such a great part of EMDR.
Gosh, Abigail, that's really powerful. And just from an imagistic perspective, thinking back to sort of consoling your 8-year-old self where the source of the trauma did occur is super powerful, actually.
So powerful. We have such resources now as adults and such ability and knowledge. And what we need to do is we need to take that back to the early us, the early children around us. And sometimes it might be standing up to a bully that actually you go back now. And there's one protocol called the anger protocol, where you say everything you never got to say to that bully, or everything you never got to say to that abusive parent, and you tell them exactly how you feel, and you script it like a movie, what happens next. And these people might have died, these parents might not be around anymore, but you re-script it and you become successful in that memory, and you have the say that you never got to have before, and then you process it and it becomes installed, and that person takes it with them. It's fantastic.
So, Abigail, have you had personal experience of EMDR therapy?
I needed to use it actually not that long ago. It's difficult being a therapist and having therapy. You have to go on the other side of the chair. But I do believe it's important that we get to experience the therapy that we give. And I had a pretty tricky time. I had a cancer diagnosis last year, and I've healed physically, but emotionally, it's a tough road. For any of you listeners out there who've had cancer diagnosis, I feel for you. It takes a long time to feel safe again in the body, even when the cancer's gone. It can haunt. And for me, EMDR was so powerful for that, because it helped the new adaptive information, which is, I am safe now. The cancer has gone. I don't need to feel like an axe is going to land on my head any day. And I needed that to be installed in the moment of diagnosis from last year, just to realize that it's the past now. So I had a brilliant EMDR therapist, and she really helped me. We identified the exact moment which was most bothersome for me. And the cognitions within that for me was, I am unsafe, I'm going to die soon. That's what I kind of got encapsulated. And then we processed that, and it was all remote. And then we installed a new adaptive thought of, I'm safe, I survived. And that's what I carry with me. And it's not like sometimes with CBT, you're trying to force yourself to believe the new thought. That's not EMDR. You just, because it's been processed, you just do believe it. It's just there and it's real. And for me, it's changed everything. I know I'm safe, but I feel it deep down now that I'm safe, as safe as you can be. But I believe EMDR gave me that gift of recovering emotionally from what happened.
So, Abigail, what would you say to listeners that are struggling with traumatic feelings, and what should they do with them?
I guess, first of all, my heart just goes out, because trauma is tough. It's tough. I mean, life is tough as it is, but trauma, it doesn't leave us always, and we carry it with us, a little part of us. So I guess, please be compassionate to yourself. Be kind. Try not to get in the habit of avoiding and punishing. I must get rid of this, what's wrong with me, because that's not going to be helpful. It's going to put you in a state of further stress. Try to be compassionate, but be inquisitive. Think about, well, what's triggering me? And it's okay to be triggered, but what do I need to do to help myself feel safe and help myself feel okay? Watch for abusive, negative thoughts, because they're just adding to the problem. And I really would encourage you to seek out an EMDR therapist. In the UK, we have them in the NHS. Seek them out in the NHS. There's private therapists. I think there's some charities that offer it. It can be online. It can be face-to-face. It can be accessible. And again, it doesn't have to be many, many months and months of therapy. For a lot of people, you can see change in 10 sessions, sometimes even less than that. It depends how deep it is, and depends how stable you are as well. For some, it can take longer, because it's important a client is safe and stable before EMDR is done. So that can be the bit that can take longer. But particularly if you've just had a one-off event, it can be processed so quickly. So please just be brave, seek out. There's so many services out there that can be really helpful.
So listen, that's fantastic. And just as we come into land on the conversation, actually, that's super comprehensive Abigail, and really does contextualize EMDR, but also speaks to the utility of it, the absolute life-saving utility of it. So if people wanted to reach out to you, because that was really fantastic, some of the information you've just given, how would they reach out to you, Abigail?
I'm very fortunate to run a private practice in Malvern, Worcestershire. I'm the clinical director, and there's 12 therapists, and the majority are trained in EMDR remotely as well. And that's children, adolescents, and adults. So just reach out for us. We try to make it really accessible. You can do it all online with self-referral forms. Our website is malvernhillsprivatepractice.co.uk. Or if you want to know a bit more about me, I've got the website drabigail.co.uk. And I'm trying to get more videos out there on YouTube. It was supposed to be weekly, Owen, but lockdown and homeschooling has interrupted that. But it's my passion to let people know, because I have so much training and I just want to disseminate this information to people. So have a look at that. I'm starting to produce more videos. Alternatively, you can send an email to Abigail at Dr. Abigail, that's DOCTOR, abigail.co.uk. I'm always happy to hear from people, and we'll try and point people in the direction of services that can be helpful for them.
Listen, that's amazing. And we'll put all those contacts in the show notes, including the links to the YouTube channel, because there's some fantastic content on there and some really succinct and valuable educational material. So we'll definitely do that. It just leaves me to say thank you so much.
It's been lovely to meet you. And just thank you for taking the time, Owen, to talk about EMDR with me, because I just think it's great to get it out there. And hopefully through this conversation, more people can be healed and move forward and just live their best life.
Absolutely. Thank you, Abigail.
Thank you.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.